Safety Institute, CPSI. So just a reminder that this webinar will be recorded, and the link to the recording will be posted on the MedSafety Exchange website about a week later. And we have all the lines muted, so we encourage any questions or comments to be typed to us in the chat box, and then we'll read them out loud at the end of the webinar during the discussion period. So the purpose of this webinar series, as you know, is to bridge the silos in healthcare reporting and sharing and provide a platform for us to share and learn from one another so that we can minimize the recurrence of med incidents and optimize med safety in all care sites. So we are happy to provide certificates of attendance for each webinar to support your continuing education requirements. These are now available for $14.99 plus tax, which just helps offset administrative fees and supports the program. You simply have to visit the MedSafety Exchange website and click on the green Request a Certificate button under the desired webinar, and then fill out the form for the certificate to be emailed to you. So certificates are available for all past webinars, so you can click on any of those listed dates. Now for today's overview, this webinar will have one med incident analysis regarding the perpetuation of confirmation bias and how multiple safety barriers were bypassed due to LAHSA drug names and other factors. And then we'll have a description of learnings from other jurisdictions regarding electronic prescribing. And this will be followed by the observatory for a med safety update by the Canadian Nurses Association and CPSI. And then we'll finish up with a discussion period where we read out your comments and questions and we keep the learning going. Anonymity is still a choice for all those involved in the webinar, so I'll only introduce speakers briefly, and they can choose to share as much or as little as they'd like about themselves or their practice site. I'd like to invite the first speaker to discuss an incident analysis about confirmation bias with LAHSA drug names and the multiple system failures that perpetuated it.
Good afternoon, everyone. Can you hear me okay?
That's great, Jess.
Okay. Hi, my name is Jessica. I'm a pharmacist working currently at Tattle Creek Family Health Team in Toronto, Ontario. I've been working here for the last 5 years, and I wanted to extend my thanks to ISMP Canada and CPSI for inviting me to share this medication incident with you all, with the goal of raising awareness about look-alike, sound-alike drug names and the role of confirmation bias on patient safety and potential adverse outcomes. Okay, so let me introduce you to Mrs. B.D. This is a 92-year-old white female, and she is a patient of one of our 15 family physicians here at Tattle Creek Family Health Team. So our family doctor has known this patient for over 30 years. Now, I just listed here in terms of her relevant conditions and medications that are pertinent to this case and to this incident. So I didn't include everything just to make sure that it's really clear for you to see the issues. So you can see she has a history of atrial fibrillation on apixaban, history of heart failure on citoprolol, furosemide, and spironolactone. And of note, she does also have chronic myelogenous leukemia, which she's on hydroxyurea through her oncologist. So keep those things in mind. Now, just to summarize the incident, Mrs. BD was admitted to the hospital in April of this year with left leg cellulitis and foot pain. Now, based on her other comorbidities, while she was in the hospital, they, of course, were monitoring her fluid balance, and they adjusted her diuretics during the admission. So she was started on metolazone 2.5 milligrams twice a week, and based on adjusting in her weight and monitoring and things like that, they had adjusted it and reduced the metolazone to 2.5 milligrams to be administered prior to furosemide once weekly. And she was discharged on metolazone 2.5 milligrams once weekly. Now, when the patient was discharged, she had gone to her community pharmacy to fill the discharge prescription that was provided to her. And this is where the community pharmacy had dispensed a medication in error. So instead of metolazone, they dispensed methotrexate 2.5 milligrams once a week. And based on the quantity that was authorized by the prescription, she did receive a 4-week supply for this medication. So keep in mind, she had already taken this medication in error for a month. And subsequently, when the prescription had run out, the community pharmacy then authorized or sent out a refill request to our family physician here at Tattle Creek to refill the prescription. Now, the primary care provider presumed that it was the oncologist of the patient that had initiated the methotrexate and decided to authorize the prescription. So she was given an additional 4-week supply of methotrexate put into her blister pack. So how do we identify this error and what was the outcome? So the error was identified in June of 2018. So she had been taking medication of methotrexate in error for 2 months. So the error was identified when the primary care provider had noticed that the patient's serum creatinine was elevated and it was trending upwards. And that prompted the primary care provider to refer and consult with the family health team pharmacist to look for any potential drug-induced renal impairment and causes of elevated serum creatinine. So I just wanted to list on the right side what her serum creatinine readings were. Now, there are potential causes as to the elevation of serum creatinine. It could have been secondary to the inadvertent initiation of methotrexate, or other potential drug causes could have been she was also taking furosemide as well. So as I mentioned before, she did receive 8 doses of methotrexate in error. And what happened a week after the medication error was identified was that she was readmitted to the hospital with the most responsible diagnosis of another heart failure exacerbation. So essentially could have been caused by suboptimal control of her volume overload, secondary to her heart failure, when she wasn't taking the metolazone as intended. So let's do a deeper dive in terms of looking at the errors and what led up to this incident. So where did this error occur? So first off, it started off in the community pharmacy, where the discharge prescription was processed and dispensed as the incorrect medication. So metolazone was not given and methotrexate was given instead. The second error occurred, and the error perpetuated when the doctor at the doctor's office had filled the medication and repeated it in error, assuming the indication for the CML. So the result is that it potentially could have caused the patient to be readmitted to the hospital. So what are some contributing factors to this incident? So we're looking at, first off, confirmation bias. So not only are they look-alike, sound-alike medication names, metolazone and methotrexate, but even their dosage regimen is comparable too. So dosing 2.5 milligrams, a little bit on the lower end of methotrexate, but still seems reasonable, and a frequency just once weekly. Secondly, a confirmation bias when the primary care provider received the refill request from the pharmacy and had assumed that the methotrexate made sense for the patient for other indications. Another contributing factor is the lack of patient counseling. So it's unclear whether the patient or their family was counseled at when they were being discharged from the hospital, and also when they were picking up the new medication or discharge prescriptions from the community pharmacy, it was unclear what type of counseling or information they received there as well. Now, other things to consider is transitions of care. How does that play into a case like this? So we know, I had spoke to the community pharmacy after the incident was identified, and they did also do an analysis of how that error occurred as well. And they had mentioned that the discharge prescription itself was a bit unclear as well, because it was a printout, and then the physician or hospitalist had made some handwritten changes on it. Also, looking at prescriptions that don't include the indication listed on it can affect interprofessional collaboration. And of course, multiple prescribers. As you can see, the specialist, the oncologist is involved, and then we have the primary care provider, and then you have the prescription originally from the hospitalist. With that lack of communication between prescribers, that also perpetuated the issue. So what types of actions and preventive measures could we potentially take and learn from this incident? So looking from the perspective of the acute care hospital, from our standpoint, we're not able to tell what actions were taken over there. However, in terms of preventive measures, first off, trying to avoid handwritten changes to a printed discharge prescription to minimize the risk of confusion and transcribing errors. Secondly, making sure that there is a process for discharge counseling of the patient, whether it be by the pharmacist in the hospital or the nurse, so that the medication changes, or if new medications are started, are clearly understood and relayed to the patient. And thirdly, really trying to cultivate communication and coordinated care with the community pharmacy and the primary care provider in terms of medication changes and the rationale or indications for the medication. From the primary care team standpoint, so what happened with this incident is that, as I mentioned, the primary care provider informed the community pharmacist of the dispensing error. And they then notified the caregiver about the error and then discontinued the methotrexate. So they informed the caregiver to bring the blister pack back to the pharmacy to have it removed. And then the family health team pharmacist recommended follow-up blood work to reassess and also to have her heart failure reassessed by the primary care provider in person. Other preventive measures that we should be focusing on from the primary care perspective is looking at timely medication reconciliation by the primary care provider and the team within 7 days post-discharge. So from a primary care standpoint, Health Quality Ontario has an indicator that we're trying to meet, and it's a collaboration between primary care and acute care, where we follow up with patients within 7 days to make sure that they are taking their medications correctly and making sure that they're managing okay. So that's an indicator that we're trying to reach. Another thing is having a process for reviewing the chart, the patient chart in the EMR, when faxed prescription renewal requests are received, especially if the medication was not showing up on our EMR medication list internally. And lastly, making sure that cultivating communication and coordinated care between the primary care provider and the oncologist in this case. Because one of the ways that we found out that the error had occurred was that the PCP actually contacted the oncologist and asked if she had started the methotrexate, and the oncologist confirmed that she did not. So just a really quick plug about family health teams and community collaboration. So I know not all provinces in Canada may have family health teams, but this is a prominent type of primary care organization that we have available in Ontario, and it's been for several years now. But essentially, it's a team of physicians with other healthcare professionals, including nurse practitioners, RNs, pharmacists, social workers, dietitians, and others that work together to ensure that patients receive care based on their community needs. And in this case, because the FIT pharmacist collaborated closely with the primary care provider, it helped to more swiftly identify the incident and try to minimize harm. You know, for provinces who don't have family health teams or this type of model, there's also other ways to collaborate with the community pharmacy in terms of through the MedCheck post-discharge follow-up program as well. And lastly, through the community pharmacy, so the community pharmacist advised the caregiver to return the remaining blister packs as well to remove the incorrect medication. They also did an internal audit of their prescription checking process. Now, most of the time it's the registered technician, pharmacy technician, that scans the prescription into their system and processes prescription. But it's usually the pharmacist, when they're double checking, they're checking the order against a scanned prescription, which sometimes can be quite unclear or blurry. So some of the things that they had talked about trying to change their process at the pharmacy was to have the pharmacist check against the original prescription and to have a more clear process for patient counseling when dispensing new medications. Okay, and that brings me to the end of the presentation, and I believe there were a few questions as well.
Great. Thank you, Jess. So we'll actually have the questions posed to you during the discussion period, but I do want to thank you for sharing that incident with us. There's so many potential safety gaps. Even though the Lassa drug name and similar dosing and frequency was really the first error, it's so interesting to see how that can be perpetuated when we have multiple prescribers and we have patients being transitioned between community and hospital. So it was really great to see recommendations for multiple types of practitioners and multiple care sites. So I do want to invite the second speaker to describe what Canada can learn about electronic prescribing from other jurisdictions.
Thanks so much, Ambika. It's Mike Hamilton from ICB Canada speaking. And today I'm going to talk a bit about what Canada can learn about electronic prescribing. And the genesis of this is Canada Health Infoway's development of a national electronic, not-for-profit e-prescribing system and bringing it to Canada and rolling it out, starting small on pilot sites, but then gradually gaining momentum and getting into an entirely integrated national system. And in order to inform this, Infoway commissioned us at ICB Canada to independently sort of look around the world and see what we could determine in terms of things that are helpful in the successful uptake of e-prescribing, how e-prescribing can inform medication safety, and what other the lessons that other countries have had to go through, or what have they learned about what works and what doesn't, and what other benefits can we derive from e-prescribing. Our methodology was relatively straightforward and included a literature search of both academic and non-academic and a lot of government literature, as well as invoking a great number of our international colleagues in various places to sort of either give their impression or to direct us to people who were well informed about e-prescribing in their country. And I'm going to give you some of our learnings, and this is by no means an exhaustive list, and this is not everything you need to know about electronic prescribing, but I think it's a very good start, and there are some good, important, high-level learnings that we have. Our survey and interview participants came from really a broad range of countries in a number of stages of implementation. So some, particularly Scandinavian countries and Estonia, had very well-established and mature systems, whereas others, such as Brazil, had very, very little. The landscape in Europe is probably the most mature, and they're really leaders in this. And in fact, it's been probably upwards around 2 decades for some countries that have had at least some form of e-prescribing, and some are actually in their 2nd or 3rd iteration of electronic prescribing. And most are well established. There are some countries, however, that are outliers that do not have such a program. In Africa and South America, there's very little information available. There are, again, small pockets often associated with hospitals that have some form of electronic prescribing. In Asia, the landscape is a bit interesting because in a lot of jurisdictions, prescribers are actually the ones who dispense as well, and therefore you don't necessarily need that communication or that transaction system between prescribing and dispensing when it's the same person. What we do find in Asia is a number of outpatient clinics and what are described as community pharmacies that are associated with hospitals or large facilities, and it's more of a computerized physician order entry system rather than a true electronic prescribing system. North America is really led by the U.S., which has had electronic prescribing for a great number of years now, and probably well over 75% of prescribers are subscribed to the system, and upwards of most pharmacies are involved in some type. And this was really sort of spurred on in between 2010 and 2012 with the Affordable Care Act in the U.S., which we know of as Obamacare, which really spurred the adoption of technology through a number of incentives at the outset and disincentives as time went along. So in New Zealand, it sort of reflects Canada's experience where there's small pilot projects being rolled out in sort of a limited fashion with the goal for more nationwide adoption. And Australia mimics the U.S. in that most of the pharmacies and most of the prescribers are actually connected to one or two privately competing service providers, although the reimbursement there is almost entirely through the government, so it's cost neutral for practitioners. So when you discuss this with a great number of the countries that we did, when you do the surveys and when you go through the analysis of their interviews, a few themes arise with respect to barriers to adoption, and I don't think any of these are surprising to anyone. Probably the most prominent barrier is the cost and time of implementation. And this is no doubt related to any equipment that you need to do, but also things like connectivity, upgrading your connection to the whatever backbone or whatever internet requirements there are. And there's a number of direct costs as well, such as training staff, such as training yourself, such as just the time and effort spent in redesigning processes to accommodate more electronic transmission of information. Secondarily, one of the big barriers as well is lack of understanding of benefits, and this is particularly true amongst prescribers who perhaps already use electronic medical records and believe that that is what electronic prescribing is. If you're already using a computer and you print that out, you may not appreciate what the benefits are in direct electronic communication, so it takes some time to explain that. And thirdly, and this is as well no surprise, lack of integration in workflow. If the electronic prescribing system is not well set up to work with how you perform your processes in your pharmacy or as a prescriber or as some type of intermediary, you're far less likely to engage in it. There are, however, a number of facilitators to adoption, and probably the most powerful is legislative support or directive or, you must do this. And this can come from both governments or regulatory colleges or professional colleges. And this was sort of one of the approaches taken in a number of Scandinavian countries where it's absolutely mandatory to do e-prescribing. And in fact, if you tie this to the incentive in a number of these countries, you won't get paid for your work, or there's a bit of a penalty, a financial penalty, if you do not use electronic means to convey information. Incentives are always a good facilitator to adoption, and this was, as I talked about, reflected in the U.S. approach, where financial incentives for the acquisition of equipment and connectivity really spurred on adoption of e-prescribing. And conversely to what we talked about, poorly integrated systems, well-designed systems themselves, but also well-designed implementation plans. So there's always a transition period between paper and electronic, and at some point pharmacists in the community will probably have to deal with paper, with faxes, with verbal, with telephone, and with electronic. And coming up with a good implementation plan that spans this transition time is critically important. We looked at some of the societal benefits, and there are a great number, but I just thought I'd highlight a couple here. Patients with e-prescribing are actually more likely to have the prescription filled on a first fill basis. So a recent study demonstrated that the non-filling was significantly reduced if you went from paper to electronic prescriptions. So in this case, the patients would benefit from the pharmacologic action of the drug rather than just not filling it. Secondarily, public-private insurers, and I count governments among this as a type of public insurer, do notice reduced duplication of prescriptions, so you're far less likely to get a second prescription for the same thing in short order if it's electronically prescribed. And if your electronic prescriptions communicate with some data repository, because electronic prescriptions have to be in some type of standardized format, governments notice better data, so they're better able to analyze that and make policy decisions or make programming decisions. So I'd be remiss, of course, as a medication safety organization if we didn't talk about medication safety. And there are elements of medication safety that span everybody involved in e-prescribing. Certainly improvements in legibility on the form of prescribers. You don't necessarily even have to worry about legibility. And also, if your system has some sort of communication portal directly between a pharmacist and a prescriber, there's a reduction in the communication vulnerabilities that we see with either faxes or verbal reports on phones. Pharmacies, of course, if you don't have to transcribe from the paper prescription into your own pharmacy software, you get a reduction in the transcription vulnerabilities. And you also get more complete prescription information because of the way the systems are set up, that you need a certain amount of mandatory fields such as dose, frequency, and that sort of thing. So you have less time that you have to chase down the prescriber for clarification. Patients, as I've noted, have a better primary adherence. They are less likely, of course, to lose or misplace prescriptions. And they give us a sense in some of the surveys of improved communication between prescribers and pharmacies amongst their care team if information is transmitted electronically and instantly. With any new system or with any new way of doing things, of course, there are going to be unintended consequences, and it's sort of critically important that we pay attention to these. In certain systems, there are capability for free text fields, and prescribers often use them to clarify or to add instructions to the prescription. But it is a source of vulnerability. In a recent study from the U.S., 15% of e-prescriptions contained free text, 20% of which had contradictory information to other fields on the prescription. So this is indeed a vulnerability and requires time for clarification. You also tend to lose the patient double check via the paper prescription, and that's where you hand the paper prescription to the patient and they're able to sort of quickly glance at it to make sure their name's correct, to make sure they recognize the drug and dose that they've been prescribed before, and you lose that if the patient doesn't get access to that if it's sent electronically. One of the risks of dispensing is dispensing of discontinued and canceled prescriptions, in particular if the system that you work with is not well connected. So if your prescriber, if someone in a hospital stops a medication, sometimes that information is not communicated to the pharmacy. And secondarily, sometimes in some systems, modifying prescriptions is a little bit more difficult. Controlled drugs remain a significant issue, and electronic prescribing, I think, can help with that. Certainly reduction in forgeries, but also notably a reduction in doctor shopping can occur. In some systems, it may be easier to prescribe smaller quantities more frequently, and the patient doesn't seem to be bothered by that. And certainly if your system connects with prescription monitoring programs, then you certainly can have better oversight of opioid prescribing. So what have we learned, really? There are indeed societal and safety benefits to e-prescribing, but the nature and extent of that really is dependent upon how the system is set up and what other subsystems in the healthcare infrastructure it connects with and talks to. It's also critically important to integrate the e-prescribing system into the systems that you have, but a national e-prescribing system really does allow opportunities to design safety enhancements if you can superimpose things like interaction checking, if you have a relatively robust allergy database that it can communicate with, and in some cases it can make recalls of medication easier to deal with. However, we know that no existing system is perfect. There are a number of safety considerations that are both old that we know about, but we have to be aware that there may be new ones. And there are a number of change management and transition issues that are going to come about because of this. So the future is right around the corner. Prescribeit from Canada Health Infoway is the only national not-for-profit e-prescribing service. It's currently in rollout in a number of communities in Ontario and Alberta. However, there is a much broader scope in mind across the country in various types of pharmacy management systems and electronic medical records. And indeed, I think all of us will agree that safety and improvements can benefit enormously from that. And if you do want to learn more, please visit the website at prescribeit.ca and look forward to our upcoming IACP Canada Safety Bulletin.
Great. Thank you, Mike. I think it's especially important to think about those unintended consequences in addition to the benefits. So hopefully forewarned is forearmed as we embark on this in Canada. So we'll now get into the observatory for some quick med safety updates. I'll ask a representative from the Canadian Nurses Association to give us an update on the nursing leadership with the Choosing Wisely Canada campaign.
Great. Excuse me. Thanks so much, Ambika. So my name is Carrie Schuhendler. I'm a program lead for public policy at the Canadian Nurses Association. And this is just a quick update here on what we call helping nurses and patients to choose medications wisely. And it's just focusing on some of the work that we've done through the Choosing Wisely Canada campaign that relates to medication safety. So for those who might not be familiar, the Canadian Nurses Association is the national and global professional voice of Canadian nursing. We represent nearly 140,000 registered nurses and nurse practitioners in Canada. And our work advances the practice and profession of nursing to improve health outcomes and also to strengthen Canada's publicly funded not-for-profit healthcare system. So you can follow us on Twitter if you are interested in some of the work that we do or like this information. We post frequently about lots of the work that we do. So getting down to the meat of things, for people who aren't familiar, the Choosing Wisely Canada started in the United States in 2011 and was brought to Canada. It was brought to Ontario first in 2014. And it's a campaign that's aimed at reducing tests, treatments, and interventions that lack benefit or cause harm. So clinicians develop a list of recommendations. The recommendations have a stem that is a don't statement. So, don't prescribe this medication, without assessing these things first kind of thing. And the campaign, when it started, was a physician-led campaign. So in 2016, I apologize, I now see a typo that we've gotten a time machine somehow, that CNA and Choosing Wisely, we partnered in 2016 to develop the first non-physician clinician list. So nursing was really pleased to be able to be in that space, developing recommendations for nurses and nurse practitioners on reducing tests, treatments, and interventions that lack benefit or cause harm. In January of 2017, our inaugural general nursing list came out. In November of 2017, on Antibiotic Awareness Day, we released our first specialty list that was in partnership with the Infection Prevention and Control Canada, or IPAC Canada. And in April of this year, we released our second specialty list in partnership with the Canadian Gerontological Nurses Association. So what does that have to do with, why we're here today talking about medication safety? So on each of those lists, there are some medication-related items. And so they coincide with some of the sub-campaigns that Choosing Wisely has. There's a sub-campaign called Antibiotic Wisely, which is about antibiotic stewardship. And there's also a sub-campaign called Opioid Wisely. So for each of our lists, we have considered the possibility of developing items related to both of those and develop them based on our Delphi process. It's a bit of a lengthy process to develop the items. So depending on expert consensus and priority areas, we've developed items accordingly. And basically, they focus around the principles of medication stewardship and recognizing that more is not always better. The next bullet talks about the role of the nurse. So I think, you know, for us, the Canadian Nurses Association, it's really important to highlight the fact that while nurse practitioners do have prescriptive authority and are able to prescribe medications, and some registered nurses are able to prescribe medications, certain sets of medications in varying jurisdictions across the country, the majority of registered nurses do not prescribe at this time. However, there is absolutely a role for nurses to be involved in these conversations with patients. So as I mentioned, the campaign aims at reducing overuse of tests, treatments, and interventions that lack benefit and cause harm. There's lists that are developed for clinicians with recommendations, and then there's also opportunities to develop corresponding patient resources that are in appropriate language level, without clinical jargon, to help patients and clinicians to have these conversations. So, you know, nurses, as the largest group of healthcare providers in Canada, and often a patient's first point of contact with the healthcare system, are often involved in conversations with patients about their medication. So, you know, when to use it, what happens if you have side effects, how to store it, when to use it properly, when you might want to, you know, when you might want to talk to your prescribing clinician about stopping and things like that. So even though some people may say, well, you know, if a nurse isn't prescribing this medication, why is it appropriate for them to know about having these conversations? It's because it's part of, you know, the circle of care and the fact that nurses provide care within an interprofessional concept where we all have to be on the same page talking to patients about the safety of medication. And for us, this also ties in really nicely with ISMP Canada's 5 questions to ask about your medication. So if you're not familiar with that resource, I would encourage you to go check it out. It's easily available on the web. We've disseminated it as well. And those 5 questions, you know, have people asking their clinicians, like, is this the right medication? When do I stop? Should I continue? Those kinds of things. And, you know, those are questions for patients to be asking physicians, pharmacists, nurses, and, you know, anyone else who might be involved in their care, just to get the dialogue going. In terms of medication-related items that the Canadian Nurses Association lists have, over the next couple slides, I've listed the actual items, but I'm not going to go into great detail about them because we're super fortunate to be able to provide some input on this medication safety update, but I'm conscious of time. So if you're looking for the lists or the items, a quick internet search of CNA Choosing Wisely will yield either the Canadian Nurses Association webpage that lists all 3 of our lists that are currently published, or you can also check Choosing Wisely Canada's webpage and search for nursing recommendations. But in short, we have several recommendations around antimicrobial stewardship, so ensuring that there's an appropriate indication for using antibiotics or antimicrobials and preventing overuse, and also looking at the appropriate route for administration, because that's in line with antimicrobial stewardship as well. We also have some other medication-related items that are not on the part of the antimicrobial stewardship grouping, and some of those are around overuse of antipsychotic medications for treatment of patients with dementia, and antidepressants for persons with mild depressive symptoms. So these are what some of the resources look like. On the left here, we have our 3 lists that have been developed by the Canadian Nurses Association in partnership with Choosing Wisely and, as appropriate, our specialty groups that I had mentioned, IPAC Canada and the Canadian Gerontological Nurses Association. You'll see that each of the items has a stem, so the don't statement about what the overuse is, and underneath it has a short rationale to help the clinician understand, why this recommendation is so. On the back side of each of these, corresponding with each of the numbered recommendations, are the list of resources, because these recommendations are definitely informed by the evidence. And then on the right, you see an example of a toolkit that was developed by Choosing Wisely Canada, and we highlight this because it corresponds to one of our recommendations, and also there were some nurses involved in the development of this toolkit. And it's called When Psychosis Isn't the Diagnosis. It's really about that reducing inappropriate use of antipsychotics in long-term care. And toolkits are one option of how to take some of these recommendations and expand on them in ways to provide tools for providers to implement them in practice. So what are some of the next steps for the Canadian Nurses Association and Choosing Wisely Canada? So we have two more lists that are currently in development right now, one from the Canadian Association of Critical Care Nurses, led by CNA and Choosing Wisely, and another one from the Operating Room Nurses Association of Canada. And while it's early to say, as I mentioned, we consider items around antimicrobial stewardship and opioid use, and oftentimes other medications as well. It depends on recommendations brought forward from the expert clinicians who help to develop these recommendations. The Canadian Nurses Association is also going to be sending out a national survey to connect with nurses to identify who's using these recommendations in practice, how they're implemented, and who's evaluating them as well. And then from there, from the data from our national survey, we'll look at ways that we can partner with individuals and groups to scale up the implementation and evaluation of these recommendations. So that's it. I just wanted to thank everyone and ISMP for the opportunity to participate in the MedSafety update.
Great. Thank you so much, Carrie. That's a lot of great information, great resources in a short amount of time.
Thank you.
So I'll now ask CPSI to give us an update on their MedSafety initiatives.
Thanks, Ambika, and hello, everyone. Now that it's fall, we have our annual campaign, Canadian Patient Safety Week, coming up. This year, it runs from October 29th to November 2nd, and with medication safety being the World Health Organization and a global patient safety priority, our theme this year is Not All Meds Get Along, a polypharmacy and deprescribing focus, prompting patients and healthcare professionals to seek medication reviews for at-risk populations that include patients taking 5 or more medications, patients that have recently been discharged from hospital, or patients over the age of 65. Like previous years, we have a number of events happening all through the course of the week. We have a medication safety webinar on Monday, October 29th. That will include a panel of expert speakers on the topics of polypharmacy and deprescribing. Registration for just the webinar will be open next week, so keep an eye out on our website for that. This year we have a Caption This comic challenge with prizes, so it'll be captioning the comic similar to the one you see on your screen now. We have a number of medication safety quizzes as well, so one for the public that you can share with your patients, friends, and family members, and then one for healthcare providers as well. And we're also going to be doing a virtual screening and Twitter Talk event this year of the short film, Falling Through the Cracks, Greg's Story. It's a fantastic opportunity for you to see that as well. If you haven't registered yet or you want more information, please visit our website at asklistentalk.ca, and all the information is provided there as well. And also during Canadian Patient Safety Week this year, we will be premiering a new series of our award-winning patient podcast series. If you haven't had the opportunity to listen to these free podcasts, Patient is a show about the people trying to change modern medicine from the inside out. It's a nonfiction medical drama from the perspective of the patient. All 3 of our current episodes that were released last year are available on iTunes, Google Play, and SoundCloud. And the 3 episodes are entitled Episode 1, Heartbeat, number 2, Opioid, and the 3rd titled Activist. So again, we'll be premiering a new series during Canadian Patient Safety Week. But if you haven't had a chance to listen to these powerful podcasts, please feel free again to visit our website. They're free for download on your device of choice. Thanks, everybody. We at CPSI, we're looking forward to connecting with all of you leading up to and then over Canadian Patient Safety Week. And as always, if you have any questions for us, please reach out and we'd be happy to connect with you. Thanks, and back to you, Ambika.
Great. Thank you, Steve. We're all looking forward to the Patient Safety Week next month. So I know we're running a little short on time, but we're going to try to get through as many questions as possible. Our speakers had such great learning for us today, and now we want to make sure that they get a chance to elaborate.
Thanks so much, Ambika, and thanks again to our presenters. Jessica from Tattle Creek, there's a couple questions here for you. There's 2 questions which I'll roll into one, and the first one is, was a medication reconciliation done at discharge to your knowledge? And are the discharge prescriptions in any way communicated with the primary care provider? And what sort of information does the primary care provider generally receive, and how quickly do they receive that?
Hi there, this is Jessica here. So the discharge prescription doesn't come to the primary care provider. We get a discharge summary. We get a sense of what they were admitted for, what interventions were done during the admission, and then we get the list of new medications that have been started or stopped or changed. But we don't get the actual prescription or discharge prescription per se. Generally, that discharge summary comes to the primary care provider within 48 hours, or at least that is the target in Ontario right now. Over the last few years, that has gotten much quicker. It's been much faster in terms of us getting that information, but prior it would take 5 to 7 days for us to even get the discharge summary and even find out that the patient has left the hospital. I'm just trying to see. So I think I answered part of the question.
I think that answers the question. And second question is, what about distractions and interruptions in pharmacies in the community when pharmacists are checking the prescription dispensed? Do you know if the pharmacy had a no interruption zone, or what can you tell us about that?
So that was a really good question. When I spoke to the community pharmacy that was involved with the incident, they had done a process review. They didn't mention about a no interruption zone. So that's something that I think I would bring back to them just to provide some other recommendations, because it was more of the prescription checking process that they reviewed. I don't know about a dedicated no interruption zone for checking.
Okay, great. Thank you, Jess. And just in the interest of time, we'll probably just have to send you those other questions. But for Mike's presentation on electronic prescribing, we do have 2 questions as well. So multiple primary care providers in our region have an electronic system where the prescription is faxed directly to the pharmacy that the patient identified as being their pharmacy. So how does that differ from e-prescribing?
That's an excellent question, and it goes to your definition of electronic prescribing, which we found varies from jurisdiction to jurisdiction and even person to person. If you're the prescriber, pressing send that automatically faxes from your EMR, you probably don't notice any difference. But if you're on the pharmacy side, if you're receiving this electronically generated fax, it depends on the process that you have. You may have to print it out, bring it to the other desk and input it into your pharmacy management system, or you may have it set up on 2 separate screens, which the electronic fax on one screen and your pharmacy management system on the other screen. So e-prescribing, electronic prescribing, would obviate all that and send the information directly from your electronic medical record on the prescribing side directly into your pharmacy management software and populate all the appropriate fields automatically without really any human intervention in that point.
Okay, great. Thank you, Mike. And second question, where will the pilot project be held for e-prescription?
A number of the pilot projects are already underway, and the first one was in Huntsville, Ontario, consisting of, I believe, 2 prescribers and 1 pharmacy. That has since grown, and there's a number of sites in Ontario, and I think they have moved into Alberta. So it's ongoing, and I encourage you to visit the Prescribe It website to learn more.
Okay, and
for Carrie from the CNA, we have one question. Nurses are the discipline that, in a lot of cases, have the most direct contact with the patient. Do you know what the patient feedback has been about this campaign?
Thank you so much for the question. So we have done, we have been reaching out to nurses primarily because the lists that we have developed have been for the clinicians themselves. Choosing Wisely Canada does engage patients through a variety of mechanisms, including Patients for Patient Safety Canada, to get their feedback about the breadth of about the campaign in general. So I listed 3 lists that we've developed from nursing, but there's currently, I think, more than 25 societies that have developed lists, and there's about 300 Choosing Wisely Canada recommendations. So there is patient feedback that's been available, and the patients have also been instrumental in helping to develop the patient resources and public-facing media campaigns to get it to be part of the dialogue and discourse, so that people know, you know, if you go to a clinician and you don't get a prescription, it doesn't mean your clinician is not a good one. You know, maybe the reason is because you don't need a prescription for something. So.
Okay, great. Thank you very much, Carrie. And thank you again to all of our speakers and to our participants for your questions. We aren't able to get through all the questions, but we will follow up with you by email and connect with the presenters so that we get those answers to you. We do want everyone to be part of the Med Safety Exchange, so whether it's an incident analysis or a Med Safety initiative, please email us to share the learning. And please don't forget to fill out the poll that's available on the right panel of your screen. And registration for the next webinar on Wednesday, November 28th is now open, so you can head over to the website to sign up. And I want to thank you all again for sharing the learning, and I hope you all enjoy the rest of your day. We'll see you in 2 months.